Thank our two presenters, both Kathy Hunt and Paula Macris. I hope I said it right. Both of these speakers have been actively involved in research, education, and providing lectures about not only pediatric oncology patients, but pediatric patients in general. And I could probably spend this whole hour just talking about all of the wonderful things that they have done. But I'm going to go ahead and get us started so they can share their information with us. And our first speaker today is Kathy Hunt. She's joining us from Seattle Children's Hospital, where she is actively involved in the care of pediatric oncology patients, as well as children with other healthcare needs. And today she'll be helping us understand which of the pediatric cancers have increased nutritional risk, helping us understand the nutrition intervention criteria for this population, as well as giving us some guidelines for assessing nutritional status and nutrient requirements for this population. In addition to that, she's going to cover some of the potential drug-nutrient interactions. So I'm going to go ahead and welcome Catherine and let her get started.
Oh, thank you so much, Lisa. It's a privilege to be here, and I thank you all for listening today. And I just also want to say that it's been a privilege to care for children with cancer for the past 20 years and to share my clinical experience with you all today. So this is TM. He's a cancer. 9-month history of nasal congestion, snoring, and fever. His pediatrician treated him with antibiotics for sinusitis, and he did not improve. On the day of MRI, B2 placement for nutrition risk for cardiac dysfunction due to adriamycin malignancies. I'll reread them for you today, but these are my learning objectives, starting with figures. This is steadily growing. The incidence of cancer between 0 to add in the age group between 15 to 19 per year. So this is higher in this age group, in this 5-year group, than any other. The five-year survival rate is 90 patients are diagnosed each year at Seattle Children's Hospital. One in every 570 individuals between the ages of 20 to 30 years of age is a survivor of childhood cancer in the United States. This graph shows the positive trend in cancer survival rates in children versus adults. So 30 years ago, only 50% of children under age 15 years could expect to survive cancer for 5 years or more. Today, the 5-year survival rate for these children is approaching 80%. So why so much progress in curing childhood cancer? Well, the primary reason is improved treatment protocols for acute lymphocytic leukemia. A secondary reason is high participation in clinical trials, such as those of the Children's Oncology Group. The acronym COG is a worldwide consortium of pediatric institutions with a mission to study and provide care to children and adolescents with cancer. Other reasons are that new anti-cancer medicines are being developed and tested in children, and understanding the biology of childhood cancer allows for new and less toxic treatments. Additionally, new research is promising in the area of pharmacokinetics. And pharmacokinetics is the study of how long a medicine stays in the body and at what level. This wonderful work may lead to individualized dosing of chemotherapy, which would allow for decreased toxicity or less side effects to the patient. And a final factor in improved survival rates is the interdisciplinary nature of supportive care available to families and children undergoing intense cancer treatment. So I'm just putting this distribution of common pediatric cancer wheel in just to kind of show you all how pediatric cancers break down, and this really hasn't changed over the years. So if you look at this wheel, about 50% of childhood cancers are leukemia and lymphomas, which we call liquid tumors, and about 50% are solid tumors. So why is nutrition so important? Well, the risk, approximately 40 to 80% of children can become malnourished during intensive cancer treatment due to the aggressive nature of the treatment protocols and the side effects. We also know that underweight status decreases tolerance to chemotherapy, can delay treatment, and this may ultimately increase the risk of cancer recurrence. So optimizing nutritional status increases the quality of life for the patients and decreases risk of infection. So the risk of becoming malnourished is because of these treatment side effects. The most common nutrition-related side effects are listed on the left-hand side of the slide. They are nausea and vomiting, loss of appetite due to taste changes, early satiety, and then mucositis, which is on the right-hand side. Also, narcotics given for pain and antiemetics given to manage nausea and vomiting can cause drowsiness and increase sleep time. And this can also contribute to the child not eating enough, losing weight, and developing malnutrition. Some other less common side effects but are very problematic at times during cancer treatment are something called typhlitis, which is inflammation of the typhel. Pancreatitis can be caused from usually asparaginase drugs. And then we have all the steroid-induced problems with diabetes and bone demineralization. And then the post-tumor resection diarrhea is typically kind of goes along with the neuroblastoma patients. So basically, I want to present 4 diagnoses that are more likely to result in nutrition problems at diagnosis and during treatment. And briefly outline factors affecting nutritional status. And there are many more, but due to the time factor today, I was only able to talk about 4 areas. So leukemia patients, the high-risk category, those patients at diagnosis with high white blood cell counts, 50,000 or greater, age at or above 10 years, an infant between birth to 12 months of age, and chromosomal abnormalities, Philadelphia positive chromosomes, or the T-cell phenotypes. These are all considered high-risk categories. And the reason why this is such a high-risk group is so many things are going on. These kids at some point in their treatment will need cranial radiation, and this is given to patients who have central nervous system disease or are slow early responders, which means how fast the marrow responds during induction chemotherapy. Also, the patients with T-cell phenotype are in here. It can cause immediate or short-term effects, such as the somnolence syndrome, where children can sleep up to 24 hours a day at times. And obviously, you can see that they're not going to be eating well during this. And then long-term effects, such as growth failure and delays in puberty, which we see later on. Other factors affecting nutritional status, again, can be pancreatitis from asparaginase and the problems associated with steroids. And then lastly, bone marrow transplant is often necessary for cure in this population. Moving to the AML patients, the reason why they can be at risk for malnutrition is because of prolonged immunosuppression places them at high risk for fungal infections. They also spend a lot of time in the hospital, a minimum of 4 weeks after they receive their chemotherapy and their counts nadir, up to 6 weeks. So this prolonged hospitalization causes what I call staying food burnout, where they're just extremely tired of hospital food and very dependent on having their families bring in food from outside the hospital. Often these patients in my population are tube fed while they're in the hospital because they just cannot meet their needs with food alone. The next group that's very high risk are the neuroblastoma patients, the stage 3, 4, and those with an oncogene amplification called NMIC or MIC-N. The reason why these kids pose such a challenge to the nutrition and medical team is that their young age at diagnosis, between birth to 6 years, with an average age of 3.1 years. There's significant interruption in baseline feeding patterns due to the young age, significant nausea and vomiting from the chemotherapy agents. And there is a very high need for enteral tube feeding. This was a group years ago that was primarily supported by TBN, and nowadays we have been able to successfully tube feed them throughout their treatment. Sometimes the abdominal tumors can be problematic after surgery, and I've seen some high output diarrhea in some of the patients. And they go to bone marrow transplant, and then they have a prolonged transition back to oral intake after all their treatment. Sarcoma patients I find is a fascinating group to care for. They are divided into either soft tissue sarcomas, rhabdomyosarcoma, or parameningeal, which I presented in the beginning of my presentation, or bone tumors. And bone tumors, classified as osteosarcoma, Ewing sarcoma, typically occur in the second decade of life, so between 10 to 20 years of age. They pose unique challenges to the dietitian and medical team due to high demands of growth and issues around adolescence. Other factors that contribute to them not eating are compressed chemotherapy cycles treated every 2 weeks instead of every 3 with highly emetogenic and mucosal toxic treatments. So there's a very short window of time to eat and gain back weight between their chemotherapy cycles. And then this, coupled with high energy demands, does not leave a lot of room for keeping them nourished during treatment. So let's move to nutritional assessment. So how do we keep our patients nourished during treatment? Well, the primary nutrition therapy goal, as we all know, should be to sustain and promote normal growth and development during cancer treatment. Nutrition assessment should begin at diagnosis and continue throughout treatment. A clear understanding of the specific type and stage of cancer and the treatment protocol is important. So a baseline assessment should include accurate height or length in the smaller infants and children, weight, BMI, OFC. We use growth grids for serial monitoring, making sure when we obtain our diet histories that we ask parents about use of complementary and alternative medicine, laboratory data if appropriate, and same goes with anthropometric measurements. We want to make sure that we assess calorie, protein, and fluid needs in our baseline notes and provide patients, if they're old enough, and the caregiver with appropriate education. I just want to let you know that Paula will be talking about the immunosuppressed diet guidelines, so I'm not going to cover that in my presentation. There are a variety of ways to calculate energy needs. And at our center, we are still using some of the older ways, such as the RDA. We use the RDA for age in infants and catch-up growth calculation if they're quite underweight. And in children 1 year of age or higher and up, we use the basal metabolic rate tables times factors. And these are factors that I have come to use in my practice that really work nicely in providing adequate calories to the patient. As far as protein requirements, protein needs are increased due to rapid cell damage and turnover, and also due to the increased demands of growth. And if patients are in the leukemia and lymphoma categories and are on steroids, it also helps protect against loss of lean body mass. So birth to 6 months of age, we calculate up to 3 grams per kilo per day. Between 6 to 12 months, we use anywhere from 2.5 to 3 grams. And in the children, we use usually between 2 and 2.5 grams per kilo. And in the adolescent with a larger lean body mass, 1.5 to 1.8 grams per kilo per day. So the most appropriate nutrition intervention should meet the child's fluid, energy, and protein needs with the least risk to the patient. So we always start when we're working with our patients with good nutrition counseling and diet, working with the patient and family to find foods, fluids the child's able to take. They're hopefully higher in nutrient density or are palatable, which we know can also be a challenge. And smaller frequent meals are often better tolerated than 3 larger meals. Multivitamin supplements without iron may be recommended if the child is not eating a variety of foods. However, when the oral intake is inadequate to support growth or meet needs for nutritional repletion, enteral tube feeding should be the next consideration.